In this next section, Autonomic Pharmacology II, we'll be primarily discussing the adrenergic autonomic nervous system. In the next section, Autonomic Pharmacology II, we'll be talking mostly about the sympathetic nervous system. A brief note about adrenergic pharmacology. These concepts are very heavily tested on the boards. Therefore, it's very important that you remember and review the various subtypes of adrenergic receptors, where they're located in the body, and what their effects are. Let's talk first about the alpha adrenergic receptors and their molecular actions. Alpha-1 receptors are able to increase intracellular inositol phosphate, diacylglycerol, and intracellular calcium. For smooth muscle, this leads to contraction. This is why alpha-1 receptors cause vasoconstriction. Alpha-2 receptors, however, inhibit adenylyl cyclase. For presynaptic alpha-2 receptors, this leads to decreased calcium influx, and this is why these receptors, alpha-2 receptors, when they're in the presynaptic terminal, are inhibitory because they decrease the release of norepinephrine in the central nervous and the peripheral nervous system. Beta receptors are able to activate adenylyl cyclase and increase intracellular cyclic AMP. Beta-1 receptors generally increase cardiac output, while beta-2 receptors dilate bronchial and vascular smooth muscle. Beta-3 receptors are generally responsible for activating lipolysis and thermogenesis in both fat and muscle cells. Beta receptors generally are more sensitive to activation than alpha receptors. With drugs that are able to bind both beta and alpha receptors, beta responses predominate at low doses, whereas at higher doses the alpha responses will predominate. The exception for this is norepinephrine, for which it preferentially binds to alpha receptors at lower doses. Alpha-1 receptors, when they are activated, can elicit mydriasis, which is pupillary dilation, vasoconstriction, contraction of the bladder, which causes urinary retention, contraction of the smooth muscle and prostate. Let's talk about alpha-1 receptor antagonists. The specific antagonist is phenylephrine. Phenylephrine is generally on the market today used to treat nasal congestion. The newer forms of Sudafed, PE, are basically phenylephrine. A similar drug to this is methoxamine. Phenylephrine also is used to raise blood pressure when it's given as a drip intravenously. Usually this is done in the intensive care unit. Phenylephrine can cause a rebound bradycardia because it raises blood pressure, and as it does so, will cause the heartbeat to slow down. This is the body's compensatory response to lower blood pressure. These medications also have to be given into the large central veins, because if they're given in peripheral veins, they can leak and cause digital necrosis secondary to vasoconstriction. Therefore, they have to be given through a central line. Alpha-1 antagonists, again, are specific, meaning they only bind to alpha-1 and not alpha-2. And these are prazosin, terazosin, and tamsulosin, as well as doxazosin. Prazosin is used for hypertension, whereas other medications in this category are used for BPH, or benign prostatic hypertrophy, because it will relax the prostatic capsular smooth muscle and allow urine to flow. Some nonspecific alpha-1 antagonists include phenoxybenzamine and phentolamine because they block both alpha-1 and alpha-2. These are used in the medical management of phenochromatocytoma. All of these medications are able to cause a rebound tachycardia. Alpha-2 adrenergic receptors, again, are found at prejunctional nerve terminals. And the activation of alpha-2 receptors will inhibit neurotransmitter release from the presynaptic neuron. They're also found peripherally, where they behave in a similar fashion to alpha-1 receptors. However, alpha-1 receptors are found in much greater quantity than alpha-2 in the periphery on vascular smooth muscle. Here's a diagram of how alpha-2 receptors work. So an alpha-2 receptor is situated actually on the presynaptic neuron. This is the neuron that is synapsing onto this effector cell. And as norepinephrine is released when this neuron is activated, the norepinephrine is actually able to go back and bind to the alpha-2, which inhibits the further release of norepinephrine. This is a feedback inhibition cycle. And therefore, the alpha-2 receptor because it decreases the release of norepinephrine, is considered an inhibitory receptor. Alpha-2 receptors are agonized by clonidine. Clonidine is a medication used to treat hypertension. A specific antagonist would be yohimbine, which is not really used clinically. It can be used as an aphrodisiac. Antagonists that are nonspecific would include, again, phenoxybenzamine and phentolamine, which are used in pheochromocytoma. Beta-1 receptors, when they are activated, can cause increased heart rate because of their effect on the sinoatrial node, as well as increased conduction velocity through the heart because of their effect on the AV node. When beta-1 receptors are activated, we call it slicking up the AV node because the signal is able to move very quickly from the atrium to the ventricle. Beta-1 receptors also can increase the force of contraction, which is called positive inotropy, and this effect is on both atrial and ventricular cardiac muscle. Beta-1 receptors have multiple agonists and antagonists. The classic agonist for the beta-1 receptor is dobutamine, and dobutamine is used to treat cardiogenic shock and heart failure by increasing cardiac output. Dopamine is also used as an agonist at the beta-1 receptors, but only at medium to high dosages. Beta blockers, which work to antagonize the beta-1 receptor, are used to treat angina, hypertension, and arrhythmias. Some examples of these are propranolol, esmolol, and metoprolol. Propranolol is nonspecific because it's able to bind and block both beta-1 and beta-2. Esmolol and metoprolol are both specific for the beta-1 receptor. We will talk more about these medications in later lectures, especially in the cardiac section. Beta-2 receptor activation can cause vasodilation, decreased preload, muscle tremor, glycogenolysis, uterine relaxation, and bronchodilation. Beta-2 receptors are classically thought to be in the lung. An activation of these receptors dilates bronchial smooth muscle. Beta-2 agonists are generally used to treat asthma. The short-acting beta-2 antagonists include albuterol, which is used in a puffer for acute asthma attacks. It can also activate beta-1 receptors and therefore can cause tachycardia and nervousness. Salmeterol is a more long-acting beta-2 agonist, and it is more beta-2 selective. It's used for chronic asthma therapy. It's generally not for an emergency situation. Beta-2 agonists, as you can see here in this cartoon, and theophylline, as you can see here, both are able to lead to increased cyclic AMP concentrations. Beta-2 agonists will activate adenylyl cyclase, which causes conversion of ATP to cyclic AMP. Theophylline is able to block phosphodiesterase. Phosphodiesterase job normally is to convert cyclic AMP to adenosine monophosphate, or AMP. When this pathway is blocked, it increases the concentrations of cyclic AMP. And cyclic AMP in the lung causes bronchodilation. Other beta-2 agonists include terbutaline. Terbutaline is given to pregnant women to relax uterine smooth muscle to stop premature labor. The adrenergic receptors, again, are broken down into alpha and beta subtypes, and then further divided into alpha-1 and alpha-2, as well as beta-1, 2, and 3. And as you can see, the effects are very wide. As we talked about before, beta-1 receptors can cause increased heart rate and inotropy. Beta-2 receptors, when activated, can cause vascular and bronchial smooth muscle relaxation. Alpha-2 receptor is an inhibitory receptor, and alpha-1 receptor is a vasoconstriction-related transmitter. Epinephrine, which is an endogenous adrenergic chemical, is a stimulant of both alpha and beta adrenergic receptors. It has complex effects on multiple target organs and has prominent actions on the heart and vascular smooth muscle. When a patient is very ill and has a low blood pressure, we will give epinephrine because it will increase cardiac output through the heart by increasing the heart rate, and it will also increase the blood pressure by causing vascular smooth muscle to constrict. When epinephrine is administered to a patient, usually in the emergency setting, it causes multiple effects because of its ability to bind multiple receptors. Epinephrine, when it binds to the alpha-1 receptor, will cause vasoconstriction of many vascular beds. This will cause an increase in blood pressure. It will also increase heart rate because it binds to the beta-1 receptor. And it will increase the strength of contraction through the beta-1 receptor and positive inotropy, which increases intracardiac calcium concentrations. It will also cause vasodilation of skeletal muscle large vessels through beta-2 effect. This will actually lower the diastolic blood pressure in some cases. And it will also dilate the bronchial smooth muscle through the beta-2 effect as well. The end result of epinephrine administration is generally a modest rise in the mean arterial pressure with an increase in systolic pressure, but a decrease in diastolic pressure, and this is because of the beta-2 and the beta-1 effect. The pulse rate will accelerate and then slow down. And this is because the vagus nerve, sensing the increased blood pressure and increased heart rate, will cause a compensation and decrease the heart rate through the parasympathetic nervous system. And this is a diagram of over time. And this is increasing. And you will see that the blood pressure, systolic blood pressure, this is systolic, this is diastolic in red. And this is the mean blood pressure in the middle. And you can see that after giving epinephrine, you see a nice increase in the systolic blood pressure. And that's because of the alpha-1 effect. Because of the beta-2 effect, which is the dilation of the smooth muscle in the skeletal muscle, you can see that that decreases slightly. But the overall increase in blood pressure, in mean blood pressure, is what's most important. And then because of the beta-1 effect, you can see that the heart rate increases in this patient. And over time, that will wear off. For step 1, you're going to encounter problems where you give epinephrine either with an alpha blocker or a beta blocker. This is designed to test your ability to understand which receptor is responsible for which action. Remember that epinephrine plus an alpha blocker will leave the beta effects unopposed. And that would be the increase in heart rate with the prominent vasodilation, which is because of the beta-2. And this will also cause a drop in the mean arterial pressure. This is also known as epinephrine reversal. Remember, with an alpha blocker, I'll go back, with an alpha blocker, you would lose this response. That would cause the blood pressure to go down, actually because of the beta-2 effect, lowering the diastolic blood pressure. Epinephrine plus a non-selective beta blocker would cause prominent vasoconstriction because all you would see is the alpha-1 activity, which would cause vasoconstriction. You would not see the beta-1. You would not see beta-2. You wouldn't see the increased heart rate or the dilation of the skeletal muscle vascular beds, causing a decrease in diastolic blood pressure. Norepinephrine is another adrenergic chemical that has potent actions at the alpha receptors as well as the beta-1 receptor, but very little action at beta-2. When a patient is given norepinephrine, and usually this happens in the ICU or the emergency setting, because of the alpha response, both the systolic and the diastolic pressures will increase. This causes a compensatory vagal action that slows the heart rate down. Your cardiac output, because of the blood pressure increase, will not be increased, because increased blood pressure causes increased afterload. And as the afterload increases, cardiac output will decrease. Peripheral vascular resistance, however, increases greatly, and that's because of the alpha-1 signaling. This is a diagram, again, showing that with norepinephrine, you see mostly an alpha-1 response. You don't see so much of a beta-1 response. Remember, norepinephrine is the exception to the rule that beta usually binds before alpha. With norepinephrine, you see the alpha before beta. Okay? And this vagal reflex here shows that the heart tries to lower blood pressure by decreasing the heart rate through the vagus nerve when it senses that the blood pressure is markedly elevated. The pressor effects of norepinephrine are abolished by alpha antagonists. Because norepinephrine does have slight beta-1 effects, by giving alpha antagonists, you're able to see those beta-1 effects. And those alpha antagonists are the chemicals that we talked about before, phentolamine. The strong vasoconstrictive effects of norepinephrine can be seen if you give norepi plus a beta blocker such as propranolol. Isoproterenol is an interesting drug that's a non-selective beta agonist, meaning it can bind to beta-1 and beta-2 and activate them. It can lower peripheral vascular resistance through binding to beta-2, and it can increase heart rate and contractility because of its beta-1 effect. And beta blockers are able to block the effects of isoproterenol. The effects of isoproterenol in terms of heart rate are very evident. As you can see, the beta-1 activity raises the heart rate. The beta-2 activity and dilation of the vascular smooth muscle in skeletal muscle beds causes a decrease in the diastolic blood pressure. This causes a decrease in the mean arterial pressure. The increased heart rate actually tries to increase the systolic blood pressure a little bit, but the general mean arterial pressure goes down. Remember, giving a beta blocker should block the effects of isoproterenol. Alpha blockers should have no effects on isoproterenol. And this is a diagram showing all three drugs given to the same patient over time. And you can see first we have epinephrine, then norepinephrine, and then isoproterenol, and their effect on blood pressure. Also, remember the response that you see in the heart rate. Epinephrine raises heart rate. Norepinephrine actually decreases heart rate because of the reflex bradycardia. And isoproterenol will increase heart rate because of the beta-1 activity. Isoproterenol is generally given to patients that have bradycardia. Let's talk about beta blockers for a second. Again, we'll be talking much more about beta blockers during the antihypertensive lecture. Propranolol was the first or prototype of beta blockers. Common boards questions will deal with propranolol and the adverse effects. Propranolol used to be very popular, but is not so popular anymore because it is non-specific, meaning it can block both beta-1 and beta-2. It can cause bradycardia and AV block. It can actually worsen asthma because it blocks beta-2 receptors. Remember, beta-2 receptors are responsible for bronchodilation. So blockade will actually cause aggravation of breathing. And it can actually worsen diabetic patients who rely on glycogenolysis to raise their blood glucose levels. The clinical uses of beta blockers are many, including hypertension, cardiac arrhythmias, heart failure and angina, as well as anxiety, tremors, and glaucoma. Beta blockers, again, are classified by the duration of their action and the selectivity, meaning how sensitive are they for one receptor versus another. Beta blockers are also classified in their ability to completely block or partially block a receptor. Pindolol and acebutolol, for example, are actually weak partial agonists. They can act, however, as antagonists if there is high adrenergic activity. As we mentioned before in the partial agonist lecture, these compounds can displace full agonists and therefore act as antagonists if there is a lot of full agonist around. They're able to cause less bradycardia and AV block because they don't have the same efficacy as antagonists. Beta blockers are also classified by their ability to bind alpha and beta receptors as well. Carvedilol and labetalol have not only antagonistic activity at the beta receptor, but also at the alpha receptor. This is why they're important for both heart failure and cocaine overdose. Remember that cocaine is able to activate both alpha and beta receptors. So giving a beta blocker only will lead to unopposed alpha activity, which causes severe vasoconstriction. This is why in a patient that's overdosed on cocaine, it's important to use a beta blocker that has alpha blocking activities such as labetalol or carvedilol, and we'll talk more about that later. This is a chart that shows the different categories of beta blockers. The first category is the older category of beta blockers, including propranolol, nadolol, and timolol. Propranolol these days is more generally used for panic disorders and anxiety attack. These medications also, propranolol and nadolol, are also used in liver patients because they decrease portal hypertension. Timolol is an eye drop that's used for glaucoma. The non-selective beta and alpha antagonists, again labetalol and carvedilol, are used for cocaine overdose, hypertension, and congestive heart failure. The partial agonists, pindolol and acebutolol, are not used as commonly as other medications for blood pressure. They're commonly used for glaucoma. The beta-1 selective antagonists are the most commonly given beta blockers for blood pressure, and they include esmolol, metoprolol, and atenolol. Metoprolol and atenolol are commonly given by mouth, PO. Esmolol is very fast-acting IV drip that's commonly given for patients that have hypertensive crisis. It has a very short half-life and therefore is quick on and quick off, so it can be titrated very easily. Let's talk briefly about tyramine. Tyramine is a chemical that is present in certain foods and beverages, such as cheeses, fava beans, Chianti, and certain beers. Tyramine is rapidly metabolized by MAO type A, monoamine type A oxidase, in the GI tract and the liver. So normally it doesn't cause a problem in most patients. However, patients that are taking a monoamine oxidase inhibitor, such as phenelzine or trenylcypramine, they need to restrict their diets of tyramine, because high levels of tyramine can cause displacement of norepinephrine from neural vesicles and cause hypertensive crisis, increased blood pressure. This is why patients taking MAO inhibitors need to restrict their diets of tyramine. Amphetamines, which are certain medications that are used for attention deficit disorder and sleep disorders, are able to work by increasing norepinephrine release from nerve terminals, which in turn causes peripheral sympathetic stimulation. Amphetamine also increases the release of dopamine in the central nervous system, which can cause psychosis-like syndromes, which resemble schizophrenia. Clinical uses of amphetamines, again, attention deficit disorder, narcolepsy, and they can also cause short-term weight loss. Ephedrine is a compound that was commonly used for weight loss prior to 2004. It's a similar compound to amphetamines, though it's not used for ADHD or narcolepsy. In 2004, it was shown that patients that were taking ephedrine had a higher incidence of sudden death, especially when used by athletes. Therefore, this medication has been removed from the market by the U.S. Food and Drug Administration. Cocaine is a Schedule I compound that has been shown to block norepinephrine reuptake, which increases the concentration of norepinephrine in the synaptic cleft. This causes both peripheral and autonomic and central effects, including vasoconstriction, which increases afterload, which increases cardiac work, which can lead to myocardial infarction. It also causes tachycardia and possible arrhythmias. The most common cause of heart attack in a young man is the use of cocaine. Cocaine also is able to block dopamine reuptake, which can cause CNS effects and psychosis, as we talked about before. There's no specific antidote for cocaine overdose. Again, we talked about giving labetalol because it's able to block both alpha and beta receptors, which will prevent hypertensive vaso-occlusive crisis. Again, the way cocaine works is by blocking the reuptake of these blue nerve vesicles from the synaptic cleft back up into the preganglionic neuron. This increases the concentration of norepinephrine and dopamine. And as you can see here, the way cocaine works by blocking the reuptake of these chemicals back into the presynaptic neuron. And this can occur both in the central nervous system as well as at the target cell. So this occurs at the CNS and at the peripheral nervous system, the PNS. And the effects seen in the central nervous system would include euphoria and paranoia as well as hyperthermia. From the peripheral nervous system, you can see the hypertension, the cardiac arrhythmias, myocardial infarction, and cerebral hemorrhage can result because of increased blood pressure and increased heart rate. Let's talk for a second about dopamine receptors. These receptors have complex actions because you have multiple receptors depending on the dose that can be activated by dopamine. D1 receptors, when activated, can cause dilation of renal, mesenteric, and coronary vasculature. And this is because D1 receptors, when activated, will activate adenylyl cyclase and cause increased cyclic AMP production inside the smooth muscle cell. D1 receptors are also found in the brain and the central nervous system. D2 receptors, however, are inhibitory, and they have a less important role. They're responsible for presynaptic feedback inhibition. When patients are given dopamine, in general, a low dose of dopamine will activate D1 receptors, and this works to increase the renal and mesenteric blood flow. This is commonly used in the ICU to preserve a patient's renal blood flow. The dilated renal artery will increase the glomerular filtration rate and will allow patients to regulate their homeostasis a little bit better by increasing urinary output, UOP. Medium dose dopamine, which is approximately 3 to 5 micrograms per kilogram per minute, increases cardiac output because of activation of beta-1 receptors. This is very useful in the management of shock states, but also can precipitate arrhythmias. Dopamine, because of its effects on the heart, can cause ventricular tachycardia and ventricular fibrillation. High-dose dopamine, which is approximately 5 to 10 micrograms per kilogram per minute, will activate the alpha-1 adrenal receptors. That can cause vasoconstriction. This will increase systolic and diastolic blood pressure. This can lead to adverse effects like peripheral ischemia and necrosis and gangrene, especially of the extremities, because alpha-1 causes vasoconstriction, and that decreases blood flow to the fingers. This is the final slide in this section. This concludes Autonomic Pharmacology II. Next, we'll be moving on to some of the other types of neurotransmitters seen in the autonomic nervous system.